So good evening, everyone. For those of you who don't know me, my name is Nicole Bruton. I'm one of the Helen Joseph ED MOs, and Tammy just asked me to do the talk that I did at Helen earlier this year on the physiologically difficult airway. So I decided to do the physiologically difficult airway because I think a lot of emphasis has been put on the anatomically difficult airway, and I think it's quite obvious what's wrong with these airways here and why they're going to be difficult. But I think oftentimes the physiologically difficult airway is underappreciated and sometimes more difficult to recognize, but it's just as dangerous, if not more dangerous. So we need to be aware of it and how to mitigate it, essentially. So almost 1 in 3 patients who are intubated outside of the theatre environment will experience a peri-intubation major adverse event. So patients who are intubated in the ICU and those with pre-existing hemodynamic compromise are at the highest risk. Obviously, in the emergency department, we don't generally have the luxury of fully assessing our patients to the extent that anaesthetists do for their elective cases. And we can't just cancel patients who are high risk. So it shouldn't come as a surprise that our patients are higher risk for major adverse events. But what is important is that we need to realize that they're at high risk and resuscitate them adequately before we intubate them so that we can mitigate the risks of these occurring. So predictors of peri-intubation cardiac arrest, it includes pre-intubation hypoxia with an odds ratio of 3.1, pre-intubation hypotension with an odds ratio of 6.2, and then clinician-reported need for immediate intubation without full time for preparation with an odds ratio of 1.8. So this describes a lot of the patients that we see in our ED and end up intubating in our ED. So this is why this is so important. So I essentially identified about 3 different kinds of physiologically difficult airways. Please bear in mind that these can coexist and you need to manage them individually to reduce the risks that your patients have poor outcomes post-intubation. So the most common complication of intubation in critically ill patients is hypoxia. So desaturation to less than 70% puts patients at risk for dysrhythmias, hemodynamic compromise, hypoxic brain injury, cardiac arrest, and death, obviously. And patients who are critically ill tend to desaturate much faster due to a whole bunch of reasons. They might have a reduced cardiopulmonary reserve, anemia, low cardiac output, VQ mismatching, etc. So a lot of our patients, this is just the oxygen dissociation curve. A lot of our patients are already sitting here on the curve. And from what you can see here is that even a small drop in your PaO2 is going to cause a large drop in your oxygen saturation. So what we need to do with these patients is move them as far up this curve as we can. So we want them to be in this area that says low risk, because even a large drop in your PaO2 here isn't really going to change your oxygen saturation that much. So how do we go about doing this? Essentially, we need to pre-oxygenate them appropriately. So you can start with something simple like positioning. So studies have shown that pre-oxygenation is improved and apneic time is prolonged in the back up head elevated position. So this helps take off weight from the chest wall and might improve ventilation. And it might also decrease the risk of passive regurgitation and hence aspiration. Some studies have also suggested that this might also improve the view of the glottis with direct laryngoscopy. So don't be afraid to intubate in the head up position and go against what we've kind of formally been taught when you lie the patient flat and intubate them that way. That actually might not be the best way to view the glottis. Then there's a couple of different ways that you can pre-oxygenate a patient. So you can use a face mask. So a non-rebreather or a polymask can deliver an FiO2 of 60 to 70% if you set it at a flow of 15 liters per minute. But you can increase the FiO2 to up to 90% if you increase the flow to 30 to 60 liters per minute. You can further increase the FiO2 by adding a nasal cannula with flow rates of 15 liters per minute. Alternatively, you can pre-oxygenate with a bag valve mask. and a good seal. However, if you have an awake patient, this can be quite claustrophobic for them and might not be the most comfortable way to pre-oxygenate them. So we don't have access to it at Helen Joseph, but you can pre-oxygenate with high flow nasal cannula as well. The advantages of this is that it can provide an FiO2 of up to 100%, and it doesn't entrain as much room air during inspiration and helps to flush out that expired air from the upper airways. It can also generate small amounts of positive end expiratory pressure, so up to about 5 centimeters of water. And when I was looking at the evidence, the evidence is mixed, but the advantage of high flow nasal cannula is that you can keep it on the face while you're intubated, while you're intubating, and use it as apneic oxygenation, which I'll talk a little bit about a bit later. Then you can also consider using NIV for pre-oxygenation. So there's been a few large randomized control trials which have shown a benefit for pre-oxygenating with NIV over more traditional methods like a face mask oxygenation. So one of these studies was called the pre-oxy trial, and this was quite a nice study that was done. And the primary outcome in this study was hypoxemia during intubation, which they defined as an oxygen saturation of less than 85% between induction and 2 minutes after intubation. And the secondary outcomes were the lowest oxygen saturation between induction of anesthesia and 2 minutes after intubation, as well as the rate of cardiac arrest. And in this study, the percentage of patients who desaturated to less than 85% was 9.1% in the NIV group and 18.5% in those that were pre-oxygenated with an oxygen mask. And this was an absolute difference of minus 9.4%, which was statistically significant, with a number needed to treat of 10, which was quite good. And the effect of the NIV was highest in patients who had a BMI of 30 or more. Then the rate of post-intubation cardiac arrest was also lower in the NIV group, which was 0.2% when compared to 1.1% in the oxygen mask group, which was also statistically significant. So this is just a summary of their results. So you can see the rate of desaturation at each level was quite a bit lower in the non-invasive ventilation group. So there's quite good evidence to support the use of NIV for pre-oxygenation. So moving on, we can also consider apneic oxygenation, which is essentially the use of nasal cannula to provide oxygen to patients in the period between the onset of your muscle relaxant and ventilation through the ET tube. So you can do this with just normal nasal cannula. You open the flow to 15 liters a minute and you just leave it there while you intubate the patient. And in apneic patients, this works because there's a net flow of gas from the pharynx into the alveoli, which helps prolong the safe apneic time. And in normal patients, apneic oxygenation has been shown to increase the safe apneic time quite considerably. One study that I found showed that there was no desaturation in their patients for up to 55 minutes, although obviously these patients became severely hypercapnic and acidotic. So obviously don't take 55 minutes to intubate your patient if you can avoid that. Then the last thing that you can consider when you have a hypoxic patient is something called a delayed sequence intubation. You might have heard people talking about a DSI. This is what they're talking about. So a delayed sequence intubation is essentially procedural sedation where the procedure is pre-oxygenation. So this is for patients that require intubation but who are expected to desaturate rapidly with paralysis, or patients that can't tolerate pre-oxygenation by other means. So for example, your hypoxic patients who are confused and agitated and they're ripping off their mask and just really combative, this is a really nice option for them. So first of all, you need to make sure that your patient has a patent airway. So obviously, if someone's not protecting their airway, you're not going to be able to do this. You just need to proceed with an RSI and protect their airway. But if they're protecting their own airway, it's patent, you can consider this. You need to position them in the head up position. So you want the head of bed at least 30 degrees, if not higher. And then you're going to give them a small dose of an induction agent. So generally we use ketamine, 1 milligram per kg as a slow push over about 30 seconds so they don't become apneic. And you can consider giving them another 0.5 milligrams of ketamine if you want to achieve complete dissociation. Then you can use your apneic oxygenation throughout this as well if you would like. And then you pre-oxygenate the patient however you want. You can use a face mask, you can use a bag valve mask, or generally what happens is these patients will already be on NIV. So one example is an asthmatic patient who's not doing so well, they're on NIV, they're a bit confused, they're not tolerating the NIV mask very well, and you think, okay, sure, this is going downhill, we need to intubate the patient. So you decide to do a delayed sequence intubation, and you give a dose of ketamine. And it relaxes the patient, they start breathing deeper, they stop trying to take the mask off. And sometimes what can happen is you can avoid intubation entirely. This doesn't happen very often or all the time, but it can happen, and in which case that's a win and you can take it there. But if that's not the case, you can pre-oxygenate them for 3 minutes or until their oxygenation has improved, and then you can proceed with the rest of your intubation. Obviously, the normal complications that are associated with NIV intubation, the medication that you're using, those all still apply. But one particular concern for a DSI is that it kind of goes against the normal tenets of a rapid sequence intubation in that you're giving someone an induction dose, but you're not protecting their airway immediately. So there is a risk that it might increase the risk of aspiration. So just bear in mind that that is a concern associated with this. This is just an algorithm that I found. It's essentially everything that I've gone through. It has the drug dosages available. And if you want to come back to it and have another look at it, this is just here for you guys to have a look at. The second group of patients that I identified is hypotensive patients. So there's many reasons patients might be hypotensive in the emergency department. They might have sepsis, hypovolemic, they might have hemorrhagic shock, etc. And these patients are very high risk for both peri-intubation hypotension, but also peri-intubation cardiac arrest. And then obviously you're going to intubate them, you're going to do a whole bunch of stuff to them that's going to worsen their hypotension. So you're going to give them an induction agent that might vasodilate them and cause myocardial depression. You are going to change them from their normal ventilation to positive pressure ventilation, which is going to impact their venous return. So you need to be prepared to manage hypotension in these patients. You also might start correcting their catecholamine surge. So by correcting their hypoxia and their hypercapnia, their catecholamine drive might decrease, which is going to decrease their blood pressure as well. So just be aware that that might happen. So patients that you need to be especially aware of is obviously patients who are hypotensive pre-intubation are probably going to be hypotensive post-intubation as well. But there's also patients who have a shock index of more than 0.9. So your shock index is your heart rate divided by your systolic blood pressure. So if we take a normal person whose heart rate is 60 and their systolic blood pressure is 120, that's 0.5. So that's like normal. Normal is less than 0.7. But if you have a tachy of 160 and you've got a systolic blood pressure of 120, sure, your systolic blood pressure is quote unquote normal, but your shock index will be higher than 0.7, which might indicate that there's kind of shock that is not obvious. Then patients who are older, patients with COPD, and patients with end-stage renal disease are also at higher risk of post-intubation hypertension. So in order to manage these patients, you can consider a fluid bolus if you think your patient can tolerate it. So generally, like a 500 ml crystalloid bolus should be sufficient. Or if you have a trauma patient who's in hemorrhagic shock, you can consider blood products. Obviously, if you have a patient who is grossly fluid overloaded or who has heart failure, rather not give them a fluid bolus, rather move on to vasopressors instead. So If your patient is already hypotensive or kind of borderline, it's generally easier to start a vasopressor infusion before you intubate them rather than realize they're hypotensive after you've intubated them and now you need to wait for the sisters to crack 12 amps of adrenaline, and rather just set it up before. You can always start them on a low dose and titrate it up or down as necessary, but rather don't wait until they become frankly hypotensive after you've intubated them. If the patient's not hypotensive, you're not all that concerned, generally what we always do when we intubate our patients is mix up a push dose adrenaline for them. So you put 1 amp of adrenaline in a 10 or 20 ml syringe and you dilute it with some saline, and then you can give them 1 ml boluses as necessary to maintain their blood pressure. And that's helpful if you think the patient's just having some transient hypotension from your induction, etc., but you don't think they're going to need vasopressor support for a long time. Then it's important to choose the correct induction agent. So propofol causes very significant vasodilation and myocardial depression, which causes very significant hypotension in not even just critically ill patients, in normal patients as well. And the same goes for benzodiazepines as well. So ketamine is in general the most widely used induction agent that we use in the emergency department, and it has multiple benefits. So ketamine can act as a sympathomimetic in patients with an intact autonomic system. However, please be aware that ketamine can still cause hypotension, especially in patients who are catecholamine deplete. So like I said before, patients who have a shock index of more than 0.9 or patients who have been critically ill for quite a while will or can still develop hypotension with ketamine. So you need to resuscitate your patients before you intubate them, and you need to be prepared to manage their blood pressures as well. Etomidate is another reasonable option. There are some concerns about it causing adrenal insufficiency. However, evidence is kind of conflicting about that. It's probably not all that relevant if you're just giving a single dose of etomidate. But if you're concerned, if you have a patient who's got adrenal insufficiency or septic shock or some weird endocrine thing, maybe stick to ketamine. Then, because induction agents act centrally, you can give lower doses of induction agents when there's a patient who's shocked and they're peripherally shut down, because that's all the blood flow is essentially going to their brain, and that's where the induction agents work. However, muscle relaxants work peripherally. So in a patient who's peripherally shut down, it's going to take a lot longer for your muscle relaxants to get where they need to be. So consider half-dose induction agents and higher doses of muscle relaxants. And please don't be scared to use neuromuscular blockers, because they've been independently associated with a reduced risk of post-intubation hypotension. So don't be scared to use them. It's not going to worsen your hypotension in general. Then I've included this study. It's called the Intube study, just because it highlighted quite nicely for me why we shouldn't be using propofol and midazolam. So in this study, they had a really high rate of hemodynamic compromise post-intubation. So 43% of the patients in the study developed cardiovascular instability. And then I looked at what they were using, and 42% of the patients got propofol and 36% of the patients got midazolam. So like 70% of the patients got either propofol or midazolam, which I feel is definitely the reason why they had such a high rate of cardiovascular instability in this particular study. So essentially, please avoid propofol and midaz in our critically ill patients. And then I did look at a study that compared propofol to etomidate, and propofol was associated with cardiovascular instability in about 64% of patients versus 50% of patients that received etomidate. So quite a big difference, and I think we have enough compelling evidence to avoid propofol and midazolam at all costs. Then just a quick slide about RV failure. So the physiology around this gets really complicated, but any process that increases the right ventricular afterload for instance, chronic lung disease or a PE will cause RV strain. And if the RV is unable to meet the increased demands, it's going to lead to RV dilatation, retrograde flow, decreased coronary perfusion, and ultimately systemic hypotension. And unlike left ventricular function, which improves with positive pressure ventilation, right ventricular function worsens with positive pressure ventilation. And this is due to increased pulmonary vascular resistance. So when possible, we don't really want to intubate these patients. What you want to do is support their work of breathing, support their gas exchange, and you want to do this ideally by giving them oxygen, giving them medication, and if you really do need to give them positive pressure ventilation, consider using NIV with a low PEEP with the goal of decreasing their work of breathing, limiting atelectasis, and reducing that hypoxic vasoconstriction. If you really need to intubate a patient that you suspect has RV strain, for instance, a patient with cor pulmonale or a suspected or confirmed PE, you need to do the following. So number one, you need to do a bedside echo to assess what their RV function looks like. So the RV dysfunction may or may not be obvious clinically, and a lot of the time you need to do an ultrasound to have a look and see what it's doing. So on this clip that I've included, it's a really nice example of what's called a D sign. So what you can see here is, so just to orientate you, this is a parasternal short axis, okay? This is the left ventricle, and this is the right ventricle. Yes, there's a small pericardial effusion, but ignore that. So what you can appreciate here is how hypertrophied this right ventricle looks. So the right ventricle is not generally so muscular, and you can see that in this patient, the pressures in the RV are so high that they're actually pushing that interventricular septum into the left ventricle. And this also demonstrates quite nicely that this RV has pushed the interventricular septum into the left side so much that you're actually reducing the left ventricular lumen size there. So you're reducing the end diastolic volume of the left ventricle, which is reducing the left ventricular stroke volume as well. So right ventricular failure also has consequences for the LV function as well. So the second thing you need to do in these patients, the most important thing actually, is to pre-oxygenate them properly. So oxygen is a very potent pulmonary vasodilator, and it's like the only pulmonary vasodilator that we typically have available all the time. So you need to pre-oxygenate them really well so that you can reduce that hypoxic vasoconstriction and reduce the pulmonary vascular resistance. There are other inhaled pulmonary vasodilators such as ipraprostenol and nitric oxide that we do not have access to. What we occasionally have access to, not currently though, is nitrocine. So the normal like nitrocine ampules that you get, that you generally give intravenously, you can consider giving them as a nebulized solution. So in one of the case control trials that they did, so there's no randomized control trials to support this, but there was a case control study that they did. They recommended nebulizing 5 milligrams of nitrocine over about 30 minutes through just a normal neb mask. However, at Helen Joseph at least, we haven't had nitrocine for quite some time now, and we've been using isosorbide instead, and there's essentially no evidence about isosorbide. There was one animal study I think that I found, but we haven't even established if it's safe to nebulize isosorbide. So we can't recommend even trying isosorbide at this point because we're not even sure if it is like absorbed in that route. So if you have nitrocine, great, you can nebulize it, but otherwise oxygen is all we pretty much have available. Then once you've actually gotten to the point where you want to intubate the patient, you want to aim for a hemodynamically stable intubation and with the shortest apneic period as possible, because you want to prevent hypoxia as much as possible, because as soon as they become hypoxic, they're going to have pulmonary vasoconstriction. So ideally, the most experienced person should be intubating this patient. You want to do it quickly, and you can consider fentanyl as well to intubate to blunt the intubation response, so they don't have like their blood pressure increase massively as well. So that's just my short talk about RV dysfunction. The last thing I wanted to talk about is metabolic acidosis. So patients with a DKA, salicylate toxicity, renal failure, etc. So obviously when patients develop a metabolic acidosis, they compensate for that metabolic acidosis by hyperventilating. And these patients generally are already achieving very high minute ventilations that you will struggle to match with a ventilator. In other words, you are not going to do as good a job that the patient is already doing to blow off their CO2. So in these patients, if at all possible, you want to avoid intubating them entirely. If you absolutely do need to intubate them, you will probably need to paralyze them at some point, at which point they will be apneic. And even if it's a very brief period of apnea, this might cause their pH to drop and might even precipitate cardiac arrest. So that's why you don't want to intubate a DKA. If you do need to put them on some kind of positive pressure ventilation, consider a trial of NIV while you're trying to correct the acid-base status. One advantage of this is that you can use the NIV to kind of gauge what their minute ventilation is looking like, so that if you do need to intubate them, you kind of have a minute ventilation that you can try and match. So when would you need to intubate these patients? So this is a really difficult decision, and it's one that probably should be made in conjunction with the consultant on call. Obvious indications that I can think of is like a DKA who's had seizures and their GCS is 3, and they like absolutely can't protect the airway. Those patients, you genuinely might need to intubate them. Or if it's a DKA whose precipitant is an LRTI and they're unable to compensate at all for their metabolic acidosis, you might need to intubate them as well. However, please rather discuss with a consultant on call. This is not really a decision you want to be making unilaterally. So if intubation becomes really necessary, it's really important that you minimize the apneic time. So if you're familiar with it, if it's something that you've done before, you can consider an awake intubation or ketamine-only breathing intubation. But if you don't have experience with this, I really wouldn't recommend it. It's quite challenging to intubate a patient who's breathing. So I'm not going to talk more about that, but if you have that skill set available, you can consider it. But generally, most of us will be using some kind of muscle relaxant. So if you're going to use a muscle relaxant, consider using socks because it will wear off quickly, and then the patient can begin breathing spontaneously and take over control of their breathing. Like I said before, you want to allow for the shortest apneic time. So again, you want the most experienced person to intubate. You want to bag the patient while you're waiting for the onset of your neuromuscular blocker. So I know it goes against what we all know about rapid sequence induction, but you do want to bag them while you're waiting, just to prevent their pH from dropping too much. And then if the patient was on NIV, you can also allow the NIV, depending on which ventilator you have available. Sometimes you can use the NIV with a control mode to deliver breaths while you're waiting for the muscular blocker to work. Then intravenous bicarb is really controversial. It has not been shown to increase your pH at a cellular level, but you can consider intubating under bicarb cover. But the other thing with bicarb is it gets converted to CO2 anyways. So that patient's just going to have to breathe off the CO2 that the bicarb has been converted to anyways. One place that it is definitely indicated, however, is salicylate toxicity, because it's part of the antidote. So if you have a patient with salicylate toxicity, knock yourself out, go ahead and use the bicarb. But in terms of DKAs, there's really nothing convincing to say, yes, use bicarb, or no, don't use bicarb. Then once you've intubated the patient, hopefully they haven't arrested yet, consider using a pressure targeted mode, such as pressure support, so that you can allow the patient to set their rate and tidal volume. It might be easier for them to match or to compensate for their acidosis that way. Then once you've intubated them and you need to sedate them, obviously choose a sedative that's not going to suppress their respiratory drive, such as ketamine infusions. And then you need to watch carefully for air trapping, which might occur if they have a high rest rate and a high minute ventilation. So just something to be aware of. So that's essentially the three kinds of physiologically difficult airways that I identified. Just remembering that they can coexist in the same patient, and you need to manage them, each of those things separately if you want to be successful and decrease the risk of your patients arresting post-intubation. And these are just my references. I don't know if anyone has any questions at this point. I know it's quite a lot of information, but I'm happy to answer any questions.